Thank you, Dr. Shirazi, for coming in today, and I'm excited to be moderating this discussion with you.
I'm so grateful to be here.
It is about sleep hygiene, and that is important. Today, however, our focus is on sleep disorders and interventions that can be made, which are gentle and minimally invasive. So, my first question for Dr. Shirazi is, based on all of these credentials, I'm especially interested in your traditional Oriental medicine degree and also the spiritual psychology, and just to find out how that informs your practice today.
Oh, thank you. Great question. So the dental component allows me to treat things in a functional way with oral appliances. But of course, we're not just structural beings, right? We're energetic beings, we're emotional beings, we're spiritual beings. So when I apply acupuncture and the philosophies of Chinese medicine for people with just straight insomnia, right, it seems to be a great adjunct when treating their snoring or sleep apnea problem.
Very interesting.
Yeah.
So I wanted to just give you an overview of what Dr. Shirazi is going to discuss today, and it includes snoring and sleep apnea, especially obstructive sleep apnea, which is more common than I knew. I've been learning a great deal just discussing this talk with Dr. Shirazi. Also related are migraines and headaches, bruxism, or teeth grinding, jaw clenching, and the resulting craniofacial pain, or TMJ pain. So, what is sleep? Do you want to give us a little lesson here?
Yeah, so it's a state of consciousness that every mammal needs. It's not just that every mammal has, but every mammal needs. It's what we say, it's absent from consciousness, even though there is mental activity being done. It's a way for our physical bodies to actually shut down and rejuvenate. And in fact, the only time we ever get growth hormone is during one specific stage of sleep called delta. And it's a time for mental and emotional repair and processing, and including memory, which happens predominantly in REM sleep.
And moving on, why, again, do we sleep? What does it do for us?
Yeah. So those are the main things. It restores our physical, mental, and physiological well-being. Okay? And what's really, I was just thinking about this the other day, about how evolution deemed that being vulnerable for 8 or more hours in the dark every single day is so necessary that we would even still have that while still being vulnerable to attack. So that tells me, evolutionarily speaking, that sleep must be absolutely essential. Over the years, we could not think of a better way of getting our mental, emotional rest and our physical rest.
Yeah, so this is really a need. And I just want to plug a book that I read or listened to, because I only do audiobooks, called Why We Sleep. And it goes into this a lot more. Why would we voluntarily choose to make ourselves this vulnerable for such a long period of time? You'll be fascinated, and it
is a great book.
Change the way you think about sleep. This is a map of sleep deprivation published in a 2015 study in Sleep Health. What was surprising to me is I expected to see a lot of the dark areas in urban centers, and that's not what we necessarily see across this map. Can you speak a little bit to what's significant in this?
I'll do my best, right? Because it's one metric, sleep deprivation. Of course, there can be a number of reasons why we're sleep deprived. But the occupation, for example, that is most susceptible to sleep deprivation are shift workers. People who work at night and they're sleeping when it's light outside and they're awake when it's dark outside. That's not natural. physiologically speaking. You'll notice that that map will also overlays over the rate of your BMI, you mean your obesity level, and it seems to match it pretty well. In that panhandle region is where we see the most obese, and we know that obesity can cause sleep apnea, but more oftentimes it takes whatever snoring and sleep apnea level you have and exacerbates it, which will of course deprive your sleep even more.
So as we go through the slides here, we're going to see that there's a really big connection between weight gain and sleep deprivation or sleep fragmentation even.
Absolutely. There is a correlation for sure.
Here are some statistics. A third of the U.S. population suffering from sleep disorders, 75 million individuals who are chronic sufferers, and 10%, only 10% have been diagnosed and treated.
That's right. So 3 different things to mention. So 1/3 of the population suffers from sleep disorders. That's true. Could even be a little bit more by the time this study has been out. Insomnia is the number 1, sleep apnea is number 2, and then a myriad of other neurological issues associated with sleep. And of course, the 75 million, that's for sure more now than before. What's interesting about the 10% that's been treated, that's been diagnosed with sleep apnea, yes, it's true 90% haven't been diagnosed yet, but even in that little 10% subsect, almost entirely of that 10% they've been offered a CPAP for treatment. And only about 50% of it hold to stick with the CPAP, right? So it's really more 95% of the population with snoring and sleep apnea do anything about it or even know about it.
We're going to talk about the types of sleep apnea. There are 2 major areas. And then as you discuss the problems that are associated with this, can you also tell us a little bit about why our palate is important in the treatment?
Absolutely. So the most common kind of sleep apnea, which is like 85-90% of all breathing disorders in our sleep, is obstructive. So that has to do with the way our air flows. All mammals are supposed to breathe in and out through their nose exclusively, even when exercising. This comes, most people who are runners will say, well, that's impossible. But no, actually, that's what we're supposed to do. And I'm not saying I do it. I'm just saying that's what we're supposed to do as mammals. So the size and width of our palate directly correlates to our breathing ability through our nose. The roof of the mouth is the floor of the nose. So if we have a nice wide palate, our nasal breathing will be much more patent, and we can both inhale and exhale much more freely. As soon as we have a limited ability to breathe through our nose, be it through a cold, be it through environmental allergies, or even some food sensitivities, our mouth has to dynamically change in order to breathe, because we need to breathe to survive. So as soon as this starts closing up, our mouth's open, and our mandible rotates backwards, which limits our ability to breathe. Does that make sense?
Absolutely. So basically what you're saying is the body is going to find a way to breathe.
No matter what.
And it doesn't really matter what happens to the alignment of the head or other parts of the face.
As we talk about bruxism, well, that'll become most evident.
And that's what I realized, because I definitely have bruxism, but I said, how can that, I mean, my mouth is closed, how can I also have sleep apnea? Right. So this nasal breathing and the nasal airway is truly important and a source of sleep apnea as well.
Absolutely. It could be causal.
So we're going to roll a video here that just gives you a visual of a person experiencing sleep apnea. Do you want to speak about the opening eyes?
Yes, I absolutely will. I'll talk through the video if that's okay.
That's perfect.
So you'll notice the first thing, right? The video hasn't started yet, but you'll notice on his hand he has a home sleep study device. I actually prefer home sleep study devices because it's done obviously in your own bed, and we get a more realistic response of what's going on. If I'm more concerned about your legs moving or insomnia or something more associated with the central component, I'll want to do it in a lab. Oh, there it is.
Do I need to move forward?
So you saw that his eyes just flicked open just a moment. So we're actually not waking up when our eyes open during an episode. we're actually just going from a deeper stage of sleep to a lighter stage of sleep. So we're supposed to breathe in and out through our nose. In this video shows exhaling through the mouth, but that's wrong. But when we have an airway collapse, the drop in oxygen causes the brain to tell the intercostal muscles to just sort of like little mini CPR and breathe. You need to breathe and store the airway. And you see how his eyes opened up right there? He didn't wake up. Right? So he could do that 400 times in a night and not remember a single one, because he's still technically, and through EEG we can see it happening, he's still technically asleep. Right? And then you came up with that wonderful query, which was, well, if the mouth is opening and I'm choking, how am I clenching my teeth, right? So in the studies that we see it about half the time on people that clench their teeth. We actually see the airflow starting to decrease, and then we see the masseter activity increase, and then when the airway is restored, the masseters stop clenching. Does that make sense?
The masseter is the muscle that opens and closes the mouth.
Correct. So we can even classify it as a reflex to breathing, right? And we see that about 50% of the time as the cause of clenching. Even on the very same patient that clenches their teeth because of their airway as a response, we'll see them clenching with no airway disturbance whatsoever. And in that other 50%, if you will, we put it under the category of stress, mental stress, emotional stress, or even physiological stress.
But that is still sleep apnea then.
And that second.
In the second category?
No. You can. That's
Just-
what I'm saying.
just
In the absence of an airway disorder, you can still clench 50% of the time.
But you can still help with that.
Yeah, we
Through
can.
the devices.
Through the devices, we can reduce your ability to clench 50 to 100%. That's right.
So this slide shows us some clinical signs of OSA, obstructive sleep apnea, and then what are called comorbidities. I had to look that up. So you explain comorbidity and
Yeah,
how that
all the
relates.
things that we see overlapping, whether it's correlational or it's causal. So, the first one you see up there is menopause, right? So we definitely see differences in what the patient's hormonal balance is as it relates to snoring and sleep apnea. So someone with a high testosterone content is going to be more predicated to having snoring and sleep apnea. And that's why when women go into menopause, we see a shift in the balance of their hormones more into testosterone, and then we see more apneas typically. Hypertension, it's very common. People that have uncontrolled hypertension, meaning they tried one or two or more medications and it only puts a dent in their blood pressure, very commonly, at least 80% of the time, it's the apnea that's causing the hypertension. Right?
Wow.
Obesity, it goes both ways. Like I mentioned, being obese can cause you to have snoring and sleep apnea, but can actually take whatever you have and make it worse. We see that more commonly. But also, when you're getting interrupted sleep, when you wake up, you're more tired, and therefore you want to eat more. And you're not conscious that you want to eat more, you just eat more. And that contributes to obesity, because you're eating more calories.
And that's a
throughout the day.
hormonal change that occurs.
And that's
right?
a hormonal change, yes, with ghrelin, exactly. Morning headaches, that can go in two different directions. If you have the kind of headaches where you wake up feeling kind of like an empty head, that's usually more from an oxygen deprivation, I find. Tension type headaches, which is the most common headaches in the world, that's predominantly caused by clenching your teeth and how it pinches on the nerves in the back of the skull. And like I said, the number one cause of clenching is some form of upper airway disturbance. Type 2 diabetes, we have direct, not just correlational, but causal research that shows that the inflammation that's caused from sleep apnea can lead to type 2 diabetes. And we'll actually see these very same patients being treated with either CPAP or oral appliance therapy, and their blood sugars coming down without medication. So we know there's a causal relationship. We don't say it's the only cause, but we definitely see a causal relationship.
So I went ahead and skipped to this slide that
It's a good one.
shows the correlation, just since we're discussing that. We can hop back after that. But this shows some of the hormones that are released or disturbed.
That's right. So this slide is very much a condensation. There is a whole physiological cascade that's going on. But so from the oxygen deprivation, we have the repetitive hypoxemia. You go through moments of low oxygen. But more important to that is that sleep fragmentation, right? What we call the arousal index. It's the arousals that actually cause the inflammation, what we're finding. So your arousals can come from your own snoring or sleep apnea, or they can come from your bed partner's snoring and sleep apnea, can come from a noisy neighbor's dog from construction, from a dog or a cat in your bed that's constantly jostling, or they themselves are snoring. That can cause the fragmentation. So what the fragmentation does is it causes the sympathetic nerve activity. We go into fight or flight. And that causes, well, the cytokine release. Well, cytokine release is just an inflammatory cascade. It could be not just cytokines, it could be interleukins, it could be C-reactive protein, it could be TNF-alpha. But all of those inflammatory markers will cause us to become hungrier, will cause our sugar to spike, will cause, like we said, hypertension, can lead to, we now are discovering that depression is more an inflammatory disease than it is anything else.
So really, a lot of us are walking around with a low level of inflammation that we're not even aware of.
A high level of inflammation and not aware of it. And then on top of it, this inflammation causes our blood-brain barrier to open. So now all these inflammatory markers and whatever you ate that day or drank that night that you maybe shouldn't have eaten or drinking has the ability to get up into the cerebrospinal fluid.
Oh.
And then you have the weight gain, the insulin resistance, the type 2 diabetes. But then that also contributes to more sleep apnea, because you can either have the weight gain from just gain of fat, or you can have the weight gain because you're retaining more fluid. And if you have more fluid in your upper pharyngeal area or your tongue, that will also collapse your airway at night more so.
All right. Well, let's look at that airway and go back on some of these slides here. So this is some of the points of obstruction, and then we'll look at the machinery that you use to diagnose patients.
Yeah, so we have 4 points of occlusion in obstructive sleep apnea. We have our nasal breathing, and predominantly in my observation, nasal breathing has to do with the internal nasal valves and the turbinate space, the adenoidal soft tissue, soft palate area, the tongue, and the infrapharyngeal space or throat. So any or all of those can be causal or affected, and they're all related to each other, right? So like we talked about, if someone can't breathe through their nose, they automatically mouth breathe, which shifts the position of their tongue and their jaw. That makes sense? Mm-hmm. Someone has a cold or a flu, and their tonsils and adenoids are inflamed, there's going to be a change as well.
So one obstruction can lead to another,
Absolutely.
essentially.
It's an instantaneous physiological change in order to survive and to breathe.
And what is this?
So we just have, a CAT scan in our office. It's what's called a cone beam CAT scan. So it uses just a fraction of the radiation of a traditional CAT scan. It's pretty clever. Instead of a traditional CAT scan that has like 2,000 or 3,000 microsieverts of radiation, this machine goes around your head and neck, puts a tiny burst of radiation as it goes throughout, and then it extrapolates that data into a three-dimensional rendering that is about 60 microsieverts of radiation. So, and a one-way flight to New York is 100 microsieverts of radiation. So we're talking
Minimal.
really tiny levels. And then we have the ability to then look, you can go to the next slide, to have a look at the nose and the throat and the airway. Now, about this slide and about why this is just gives us a picture in time. So what I'm actually more so than the airway in this particular slide that you put up that I'm looking at the position of the jaw. Because I'm thinking if that's what they look like when they're wide awake and, sitting up, I'm thinking, what are they doing when they're on their back and sleeping? Because in this case, they're wide awake, not sleeping. So more important to me is what's actually happening in their sleep, right? And in their own home environment. So that's why I like to do home sleep studies. I like to recommend that for my patients so they can find out what is going on.
So that would be the first step before you get to the CAT scan?
No, we
Maybe
do
we
this.
first.
We do this on the initial as well, just to kind of see what we have to work with. Because some people are just going to be a straight surgical case. Okay, we got to take these things out, or we got to fix your nose, or whatever the case may be. And some people, if they're very, very severe, unfortunately, CPAP it becomes their best option, right? But the vast majority of the people in the public that have snoring and sleep apnea fall under the mild or moderate category. So they're well within a dentist's scope of practice to treat with oral appliances.
That's good news.
Yeah,
'Cause
it just needs, we
not
just
too
need
many
more
people like
education.
the CPAP.
Yes, and actually we were talking about this just before we came on stage, was a lot of people won't even do the sleep study, even at home, because they're afraid their end goal is going to be only CPAP. So they're afraid to even just get started, even having their sleep evaluated, and that is not their only option. I like to go over the whole thing with the patient. I like to give the patient every single option I know of, and then let them decide what's good for them.
Now, we've got some slides here on the sleep cycle, a couple of
Right.
them.
That's right.
So this first one shows our REM, non-REM cycle, and then
Right.
what's significant in this? It's the same time frame, right, as the other slide?
It is. This one just goes into a bit of detail. It's actually an older slide because currently we're not measuring what's called stage 4. We're kind of mixing stage 3 and stage 4 into one. But we're actually discussing going back into measuring stage 4 again. So I'm putting it up. So the different stages that we have. So stage 1 is alpha waves. We all go into alpha waves as soon as we close our eyes. Stage 2 is a slightly deeper stage of sleep. Stage 3, and in this slide, stage 4, is the only time where we get our delta sleep, which is where growth hormone comes from. So in children, 50% of our sleep is delta, because obviously we need to grow. But after we've reached our ability to no longer grow, we now need growth hormone to repair. So growth hormone is still essential for our survival, but we're just using it to repair instead of growing. And of course, REM, like we discussed, those are the peaks that you see on that graph, where we get our mental emotional rest, our ability to retain things that we learned that day, to process things that we think are significant for our survival, both socially, right? So the brain is aware of not just our physical survival, but our emotional survival.
So sleep fragmentation is going to deprive us of a
Any one
lot
of those
of
stages.
intelligence, ultimately.
Yeah, that is true. We actually see that in children. We actually see a difference in intelligence in children that have compromised sleep due to apnea.
This has been a thing that I don't understand because now I'm a parent, so I have to take my kid to school, and I don't understand why they have to start at 8.
That's right.
And the book I referred to says, a 9 a.m. start time for schools is really a lot wiser and better for kids. Mm-hmm. So something to think about and maybe push for as a society.
The data definitely supports that on schools that shift their morning time to 9 a.m., which allows children to get more sleep, because children need more sleep than we do, they have better outcomes, less sick days, better performance in class.
We were talking last week and again this morning about the importance of breastfeeding for the development of the palate, right?
Right.
And
when we look,
why we've done a disservice by bottle feeding babies.
Yeah, twofold disservice, because when we look at skulls before the Industrial Revolution, most of them had straight teeth. Most of them had very, very wide palates. They had relatively small sinuses and big nasal turbinate space, right? And we know that the average breastfeeding period was between 3 to 5 years, right? Now, when you're breastfeeding, if you can imagine, if the nipple is inside the child's mouth, the tongue pinches the base of the nipple and then makes this little rolling action over the palate, squeezes the nipple, and gets the milk that way, right? And when they stop breastfeeding, they still swallow this way. And while we're growing, it's the tongue that actually develops the palate naturally. Does that make sense? Mm-hmm. So when we go to bottle feeding, we have a twofold problem, because one, the nipple itself is now suppressing the tongue down. And 2, you're using your buccinator muscles, that's your cheek muscles, to swallow like this, which then narrows the palate, which then raises the arch, which makes you really don't even have space for your tongue to go up there anymore because it's so narrow and high arch. Does that make sense?
Yeah,
Which
so
then
we could
compromises.
reduce a whole lot of this sleep apnea just by having children breastfeed for a longer period.
Absolutely, for sure.
Which you say right here, can sometimes be completely fixed when you discover it early enough.
So that is, I'm not sure about the data. I don't know if we've had longitudinal studies, because you have to realize understanding snoring and sleep apnea has only been going on for 40 years. You know, before that, it was just Pickwickian, where we talked about the jolly old fat man that snored and could sleep standing up. But we didn't have knowledge of it back then. It probably, who knows, it may not have even existed, you know, in that kind of numbers. But the point of that slide, that sentence, is the only time we can technically cure sleep apnea without surgery is in children through what I call what's called functional orthodontics, where we develop the palate, develop the tongue, develop the mandible forward. That make sense?
Yeah. And so in adults, what we're doing is trying to just improve.
We can improve it. The data is not as conclusive as it is for children, for adults doing functional orthodontics.
And these are just some of the symptoms of sleep apnea in kids. So
yeah, so
any of you who have kids may have noticed some of these, and it might be something you want to explore.
Yeah, the most common side effect, if you will, or symptom of snoring and sleep apnea in children or interrupted sleep is hyperactivity and ADD. That's the most common one of all. And it's because pediatric neurology is opposite of adults. So when adults get tired from sleep fragmentation, children get amped up and wired and have difficulty processing things and sitting still. You know, defiance has actually been, you know, overlapped with this as well. And it's the number of studies that have shown that correcting sleep apnea or sleep disorder breathing in the child with ADD or ADHD, and then it resolves it, is in the thousands. Wow. It's not a secret. It's not talked about, unfortunately. Most pediatricians, if you ask them about it, they would be kind of blasé about it. But it's something that's well established in the literature, and every child should be screened for snoring and sleep apnea without exemption.
Okay. Now, what about in the elderly?
Yeah. The elderly, of course, need snoring as sleeping as well, sorry. But they need less sleep than children or even adults do. But their sleep has changed depending on how active they are. So when we see the elderly population, but they're still teaching at a university level, they're still physically active, they're still getting good amounts of REM and delta. The ones that aren't, we see much less sleep. And in that population, we're seeing a lot of other neurological diseases being overlapped to it, because instead of getting hyperactivity and ADD, we're seeing in the elderly neurodegenerative disorders like Parkinson's and Alzheimer's.
So we could avoid some of those.
Potentially, yeah. So Alzheimer's has been called in the last 10 years type 3 diabetes, right?
Oh, I haven't
because
heard
of the
that one.
relationship between their inflammation and their sugar levels, which my father had, by the way. So we already know the relationship between insulin resistance and diabetes with sleep apnea. It's not a far cry to say, okay, here it is, relationship with Alzheimer's.
So taking care of this now can really help us in the future.
Yeah,
This is hard to read, so I'm just going to skip by it.
no worries.
Moving on now to the TMJ or TMD, can you clarify what is the appropriate term to talk about
Well, so TMJ,
problems with the
you hear so many
TMJ?
times, I have TMJ. Okay, so TMJ is just the name of the anatomy, right? Temporal mandibular, everyone has a TMJ. TMJ disorder is some sort of dysfunction associated with it, whether it's a disc dislocation, a broken jaw, like a fractured jaw, neck, arthritis, effusion, just swelling of the joint. It could be a disorder that falls in there, right? So that nomenclature-wise, the word TMJ just means the anatomy.
And the TMD is the actual
Disorder,
the problem with it.
That's right. And then it's sort of like cancer, where you have stage 1, stage 2, stage 3, metastatic or not. It's like we subdivide different TMJ disorders.
And we kind of spoke about this, but the tongue moving appropriately in the mouth is definitely connected to this TMD problem.
Yeah, so if you can imagine, if you're swallowing properly, if your tongue is coming forward and swallowing properly, it's going to bring the mandible with it, right? But if on the other hand, while you're sleeping, let's say, your tongue is tethered to your mandible, while you're sleeping on your back, you've effectively doubled the weight of your mandible, which will close off the airway a bit more. Does that make sense? Mm-hmm. Yeah. That's very, very hard to decipher through literature, but we see it. There are a countless number of studies where they actually do what's called myofunctional therapy, where they train you how to swallow properly when your tongue is too low in your mandible, and they'll show a 50% reduction in AHI scores of the snoring and sleep.
AHI scores?
So that's our metric for measuring sleep apnea. A stands for apnea, when your airway is closed for 10 seconds or longer. H stands for hypopnea, when your breathing is so shallow, like that causes your oxygen to dip 3% or greater. Mm-hmm. And the I stands for index, which is the number of times per hour you do the both.
So then correcting this problem, what really surprised me is that the posture can change. Yeah. So this forward head posture that I work on a lot can actually be mitigated by addressing TMD.
It depends if you have both that posture and you have a TMD at the same time. So if this is your ergonomics like all day, I don't know how much TMJ therapy is going to help you, right? But if you have a TM problem, if you are mouth breathing, which is one of the main reasons why we have forward head posture, and then you add a poor ergonomic situation where you're doing this or you're on your phone like this all the time, that is definitely going to compound it.
So we have a study here, and showed that a higher proportion of headache patients diagnosed with TMJ pain, mm-hmm. they also reported more frequent and intense tooth contact, more masticatory muscle tension, stress, and pain in the face, head, mm-hmm. and other parts of the body than the non-headache controls.
Yeah. This is something we also commonly see in the literature. Again, we're probably past 2,000 studies as well, where we see those with both tension type and migraine type headaches have much more TMJ and clenching problems than norms, mm-hmm. than just people in the normal population. And then we also see studies that show that when you address the TMJ disorder, either their tension type headaches completely go away, or their migraine type headaches can potentially reduce substantially. So we definitely see that overlap.
That is great. So here, you might want to talk a little bit about this slide and what is a migraine as compared to another headache?
Yeah, very different. So a tension type headache, when we're actually clenching, imagine all these muscles, not just the clenching muscles, but of the neck, just all going like this. We actually see a compression of the greater occipital and greater auricular nerves at the base of the skull, and it comes across here, and it can feel like a vice grip, right? And sometimes people will experience, they'll say, oh, I went to my chiropractor, they adjusted my neck, my tension type headache went away immediately. And then I slept, then the next morning, it came back. It didn't hold, right? But when it was in fact the clenching that kind of led to it. Migraine type headache. So a migraine is what we call a centrally sensitized disorder. And what that means is, you all understand what referred pain is, right? You have a pinch in your neck and it makes your arm hurt, right? That's referred pain down your arm. Central sensitization is where you have a chronic, repetitive pain that causes actual physical plastic changes to your brain, then that causes other parts of your brain to have create problems, like in the case of migraines, making blood vessels open and close.
Is that why the visual disturbances can occur?
That's right. That's along V1, absolutely. But it could also be other things. You can have burning mouth syndrome. You could have trigeminal neuralgia. These are all centrally sensitized disorders, right? And what determines which one you could potentially have is your genetics, but then it's what is creating the response of your genetics to do that. Because your genes aren't just going. I find the whole argument of migraines being genetic only is absolutely preposterous, because someone can go their whole life, 40 years, they have obviously the genetic markers for migraine, they never have a single migraine. And then something changes, they change their diet, they have sleep fragmentation, they get a jaw problem, they have a dental problem, they have a sinus problem, and then they start getting migraines, right? So it's not, we can't look at the genetics as the cause of that. We have to look at it and go, okay, what was it in their environment that created that, right? And so migraine is, if that is what your genetic predisposition is, then having chronic inflammation or chronic pain induced by your jaw, by a nasal airway issue, by fill in the blank, anything that's connected to the trigeminal nerve, can then create a migraine.
And why is the trigeminal nerve significant? I'm going to go ahead.
It's an extremely special cranial nerve. It's easily the biggest one. It's both sensory and motor. It anastomoses with other cranial nerves. And it's just really essential to our survival. It's related to our vision, our nasal breathing, and our chewing.
Anastomosis, could you?
Oh, I'm sorry. The word anastomosis means kind of merging together. So you can have a couple of nerves, like for example, along the face, it anastomoses with the facial nerve, right? So you can have a constant facial pain that then causes essential sensitization in the trigeminal nerve, because they're all connected.
Right, there's 9 nerves that actually pass through the jaw, right?
Yeah, there's several. That's right. That's right, there's several.
So this one goes back to our reptilian brain, as do most of the cranial nerves, but there's the anastomosis, right?
Yeah, well, no, that's not the anastomosis. The anastomosis is predominantly happening outside, where it starts to kind of merge together. Over here, you can kind of see how close they are to one another and how they're so close to the brainstem, right? You see the olfactory, you see the second, so they all just
Yeah, it's a big
together.
one compared to everything else.
It's much, much bigger. And that should tell you something. The brain is all about real estate. Anything that's in the brain is there because it really, really needs to be. So if we have something that takes up a lot of real estate, that means the brain puts a lot of value on it. That makes sense?
Yeah. And then I put this one in from your deck because so oftentimes people are coming to me with head, neck, shoulder pain because they've been at the computer.
Yeah.
And yet it could all be related to the jaw, or at least a good portion of it.
Yeah.
So
Exactly.
addressing that could help a lot of this.
Yes, absolutely. Just stopping the clenching or stopping your ability to clench during the day while you're working, trying to control the situation, will go a long way to relieve either the muscle pain here as it refers to other parts of your body as trigger points.
Now, there's another picture of the difference of a before and after. What was this patient given?
So this is a patient that had both a sleep apnea issue and a TMJ issue, right? So we're looking at a number of things. So there are many reasons why we can have forward head posture. One, the ergonomics, like you mentioned, is in today's climate a big problem. But if you're mouth breathing, in order to mouth breathe, you just unconsciously bring your jaw forward so you can breathe through your mouth. Does that make sense?
Uh-huh.
Because when you're nasal breathing, the air has a nice little passage of flow. But when you're mouth breathing, the air has to make a 90-degree shunt, and you have to kind of open it to make it more arced. Does that make sense? So we just unconsciously do. The brain has many reflexes built into it, many protective mechanisms, so it doesn't have to constantly be reminded of things that it doesn't consider important. So if you walked into a room that smelled very, very bad, after about 5 minutes, you stop realizing that there's a smell, because that The frontal lobe doesn't need that information. That's not relevant to your survival at that point. However, if you have a sprained ankle, your brain needs to unconsciously know that if we have to run away in an emergency, put all the weight on the other leg, right? So you oftentimes don't have to think about limping because your brain automatically does it. Same thing with breathing. When we have to breathe, the brain can't constantly be reminded that, oh, by the way, hold your head here because your nose is blocked. Okay? It just automatically does it. And then we come to swallowing, which is what we do 2,000 to 3,000 times a day. When we do it, our teeth come in contact, and if we have a jaw problem, that's when we're putting the most amount of pressure into the nerves of the jaw during the day. So then what the brain can do is unconsciously, reflexively, hold the jaw a little bit different, a little bit away from where the pain is coming from, right? But then we have to swallow again. So, well, by the way, I just recently learned myself within the last couple of years, swallowing is a survival reflex because it tells the airway that it's safe to breathe. The saliva that passes tells the brain, we're good to breathe now, carry on, right? So when we swallow and our teeth come together and the jaw goes back there, if we have a jaw problem, if you have a TMJ disorder that's hurting, much like the limping on the other leg, our jaw goes, and by exaggeration, our jaw goes forward, but then we have to swallow again, and when we swallow, our teeth have to contact. So when we do a pigeon maneuver like this. So if you can imagine a couple thousand times a day of doing this pigeon maneuver, you're going to have...
You're going to end up with forward head posture.
Potentially, yeah.
And the muscle memory that is associated with that clenching too, right?
Well, the clenching that we do is with our teeth together
Okay.
in the back position, yeah. So the CPAP, I just want you to know, I am not anti-CPAP. The CPAP works. It has something like a 98.7 success rate in treating sleep apnea, period. The problem with CPAP is that it has a huge failure in patient compliance, like 40 to 60%, depending on which study you look at. I am not a fan, I should say. I am not a fan of CPAP in children. In the growing child, I'm very much against it unless we're talking about a central problem potentially or some other kind of either brain or genetic malformation. But for the majority of the people, if you can tolerate the CPAP as an adult, I'm never going to tell anyone not to do it. Okay.
So let's look at what the other options are.
The other options exist too. You have oral appliances that do so. Whereas a CPAP is what we call a pneumatic splint. It literally pushes it. The air pressure is not designed to help you breathe. The air pressure is designed to blow up your airway, like you blow up a balloon, to keep your airway patent. Right? And so your inhale and your exhale kind of fights against the pressure, but at the same time, it doesn't allow the airway to collapse because you're blowing it open. You're allowing the air pressure to blow your tongue forward. Does that make sense?
Yeah.
Yeah. So an oral appliance is actually called a splint, like a physical splint as opposed to a pneumatic splint, where we can potentially bring the tongue forward, bring the jaw forward, lift the tongue, like instruct the tongue to go on the roof of the mouth, help with the nasal breathing by opening up the nasal valves.
Now we're talking about this type of a splint, not the kind that they form around your teeth.
No,
right?
that's the kind I'm talking about, the
Okay.
kind that's custom made to your teeth. Now, this kind of device that you have showing is what's called an ALF, an advanced light wire functional. Okay, this is a kind of what we call functional orthodontic device that we can use in children to expand their palate and literally cure sleep apnea in most. Okay, in adult, it also acts, by the way, as a myofunctional appliance because that little center loop that you see on there actually helps train the tongue where to be. Right? You know, if we get like a little hair in our mouth, we go nuts until we get it out, right? The tongue becomes acutely aware of that tiny little piece of hair because we have so many nerves on our tongue. The tongue actually seeks out that loop, and it helps train the tongue on where to swallow 24/7. But then we can activate it and then develop the palate itself, right?
So if I were to use this instead of my splint that I have, because I find my splint, I just want to clench more on it.
Yeah, okay, so
Could I stop clenching?
potentially. So let's discuss that for a moment. There was studies done, and I think you may even have the slide here, where they took subjects that had sleep apnea and clenched their teeth and didn't use their CPAP. They used a night guard instead. And we found that it made their apnea worse. And then they also clenched worse because we found that they were clenching harder in order to breathe, is the presumption. So in this, we actually have seen studies just with myofunctional therapy where there's less clenching just from knowing where your tongue is. Right? With the ALF, we're also finding that it changes your autonomic tone. It allows your sympathetic nervous system to shift more into parasympathetic and allows more calm, which allows more natural physiological reactions to happen and less of a response to the clenching. Does that make sense?
It does.
Yeah.
I'm wondering, Cleo, do you want to speak about your experience since you do actually have this device?
I do. So I have an ALF device installed. One thing that you said actually was that you're like, you can put it in children. I'm an adult child apparently because I have one of these too. And what it's been doing is it's definitely physically widening my palate, which has been amazing. But even before it was doing anything, like when he first installs it, you don't have any, he doesn't like try to make it do anything. You just let your body adapt to it initially, and it's exactly what he was saying about how my tongue was immediately attracted to the metal part on top, right there, and then I started sleeping with my tongue on the roof of my mouth, and all of a sudden I was sleeping through the night. I used to think that I was waking up 3 or 4 times a night to go to the bathroom, and I thought it was because I need to cut off my water earlier and earlier at night, and it wasn't helping. And of course I'm blaming the cat for some of this too, because he's 21. I mean, he's kind of a pain, but it turned out that I wasn't waking up because of the bladder problems. I was waking up and noticing that I should go to the bathroom and thinking that was like the causation, but it wasn't the cause. It was actually that I just was not getting good sleep, and I was getting 9.5 hours of sleep and waking up tired, thinking, well, I'm just going to spend more than a third of my life in bed because I can't seem to get enough sleep. And now that I have this device, I wake up after like 7.5 hours, and I'm like ready to go. So it's been personally, from my perspective, it's been very effective at dealing with my snoring and my bruxism. That was basically what we were trying to target. And I went to see Dr. Shirazi because I used to have a night guard, which would prevent me from grinding my teeth at night. Didn't prevent me from grinding my teeth at night. What it did was it prevented me from doing damage to my teeth when I was grinding at night. It didn't help me sleep. It just helped me reduce the amount of damage I was doing. And now I don't wear that anymore because I don't clench at night anymore, grind my teeth. So yeah, it's been fantastic.
Outside of the time where you might be sore from adjustments, does the device bother you? Do you notice it?
I don't really notice it anymore. When I have the adjustments, my teeth will be a little tender for a few days, and sometimes chewing certain things is more difficult. But it's not a lifelong thing. Like, I'm probably going to wear this for 18 to 24 months, depending on how quickly my palate and my teeth allow the movement to happen, because you have to let your body accept the change, and then after that it'll just be a night retainer to keep things in place.
So there will still be something that at least reminds your body, like you have the little loop right now.
Yeah, and I will say that what I was really fascinated about with this was that I know that I only breastfed for about 2 weeks as a baby because my mom had developed an infection and she had to take antibiotics, so she couldn't breastfeed me anymore. I also know that I sucked my thumb until I was 7. I remember because my sisters made fun of me. Because older sisters, you know how they are. And that was because, and you'll see this in children, the place where you're sucking your thumb, that spot is the place where your tongue is supposed to be. That's like the central location where it's like a calming center in your brain, is how you had explained it to me, right?
Yeah, actually, it was interesting is in Chinese medicine, you know how we have that yin-yang symbol? We actually say, because we call the back the yang and the front the yin, the moment where the yang meets the yin is right there on that spot in the soft palate.
Right, so
Right.
it's right there where a child sucking their thumb, they're actually looking to comfort themselves. and that trained my brain to, bottle feeding trained my brain and trained my tongue to just rest on the bottom of my mouth, and that causes snoring because I was choking off my airway, and the teeth grinding because my body was like freaking out because it's like, oh, you can't breathe now, you're gonna die. So that's great. Does anyone have any questions, or do you have another slide? Or was
The one slide, well, since he did bring up
yeah,
tongues
tongue
and
scalloping is so gross.
the whole tongue reading, and this, because of the traditional Oriental medicine, I noticed that there were slides where they showed the scalloping of the tongue, which means that essentially an inflamed tongue is resting against the teeth, and the teeth are making impressions on it. In Chinese medicine, that has a diagnosis, but it also is significant to this whole issue of apnea and TMJ or TMD.
Well, what's really interesting is when the whole tongue diagnosis phenomenon began, it was first documented 2,500 years ago, but it can go back 3,000 or 4,000 years, the whole tongue diagnosis and the scalloping and et cetera. But back then, obesity was not really a problem, and snoring and sleep apnea wasn't really a major problem. It was a transient thing. So what was interesting was, they didn't know that. So in today's time, we know that when someone is clenching their teeth, they're putting neuromuscular tone back in their upper pharyngeal muscles and their tongue. And the tongue only has one place to go, which is forward, which opens up the airway, but it also presses up against the teeth, and that's where you get the scallop lines. Does that make sense? So we're seeing that sort of a different thing, but then still being relevant in Chinese medicine when we see a swollen tongue because it's scalloping against the teeth. That makes sense?
Mm-hmm. And inflammation is part of that picture too, right?
Yes, because when we have inflammation, we can have edema. We can hold on to a lot of fluid, and we hold it in our tongue as well. And our tongue is actually very interesting. So if our tongue swells up because of weight gain or edema or what have you, and we even have the surgery. We actually have a surgery that takes the middle section of the tongue out and folds it back in. In about 6 months, when the pain starts going away, in about 6 months, it grows back to the same size it was before. Because we use that tongue so religiously in speech and in swallow, and to say nothing of eating, that
what about
we don't
loss
know if it's a muscle
of
memory.
sensory neurons doing something like that?
Pardon?
The loss of sensory neurons when you cut the tongue.
Yeah, it can potentially grow back because we just need it so
Even
badly.
all of the
We need it.
sensation?
So we need it because we have a lot of what's called proprioception, which is nerves that tell us where everything is. Our lips are sensitive, not because of kissing, but because we don't want to swallow or put anything in our mouth that's prickly that could potentially be a choking hazard. When we chew our food, we need to taste the food to see if it's extremely bitter and therefore could be poisonous. And we need to also double check to make sure that it's not too sharp so that we can survive. So the brain puts a lot of repair, puts a lot of nerval real estate, again, if you will, into the tongue. And that's why we see more so than any other part of the area, when we get a cut, it heals the fastest.
So unfortunately, we have reached time, and what's exciting to me is I don't see anyone leaving the room. So maybe we need to have a second talk just about the tongue. Who knows? But I wanted to put up a slide that shows where you are and how to get in touch with you. The TMJ and Sleep Therapy Center is a worldwide franchise operation.
It is. It is. It was founded by my mentor, Dr. Steve Olmos. We do have, I think as of today, 57 centers or 58 throughout the world. I have 2 of them here in Thousand Oaks and Brentwood, Los Angeles. But we, like I said, all over US, Canada, Bahrain, England, Dubai, all over Australia and Canada. We're here for you. Just you can go on that first website, tmjtherapycenter.com, to find a center near you, or you can come to our site, TMJLA or TMJ Conejo, and we'll see if we can be of service to you.
Great. Thank you so much, Dr.
It's
Shirazi.
been my pleasure. This felt like 5 minutes.
I know, it went fast.
We're going to take a couple questions from the audience, but let's give a round of applause to them in case people have to go to the next meeting.
Thank you guys so much. Thank you.
Thank you for coming here today. Quick question. So what are some active decisions or conscious decisions I can make now that would improve my sleep?
So what aspect of your sleep? So I want to give you the most relevant answer as it relates to you, because Cleo and Wendy told me that you guys have already had like little a meeting already, a Google Talk on sleep hygiene. So I don't want to be redundant. I just want to be a service to you as best. But what aspect of your sleep or what aspect of sleep would you like to address?
I sometimes feel like I wake up with pain in my neck.
Okay, that is associated with clenching your teeth and clenching your jaw like we were talking about today. Because we don't just clench these teeth, we clench the upper trapezius muscle. And then depending on where we sleep, it'll make it worse. So for example, when people have one-sided jaw problems, we see them sleeping with their hands right underneath their jaw, and they're just used to that. And they clench and they shift their jaw as they're clenching, which hurts the jaw and hurts the neck and shoulders as well. If you absolutely have to sleep like this, tuck it underneath the pillow and then do it. But then have your jaw assessed, have your airway assessed, and see, okay, why am I clenching?
Thank you.
Yeah, my pleasure. Good question.
Thank you for all the great talk. How is this wire functional that opens up the palate interacting with, let's say, the aesthetic orthodontic that many of us have?
Yes, okay, so usually in a very, very positive way. So again, we talked about what people look like prior to the Industrial Revolution. They had the nice, wide Julia Roberts style arches, nice, big, wide arches, and I find that attractive. In Europe, that's what most people have. They have nice, big, wide arches. Their parents breastfeed longer. The orthodontists in Europe are not as eager to extract teeth and bring everything back. So the Alpha appliance is devised to actually develop the arch very, very gently. So it completely transforms. I have a lot of before and after cases to show you if you like. It completely transforms the smile, right? Because it's getting that much wider.
But don't you get gaps, basically?
Yeah. So it's not uncommon after ALF treatment to do a little bit of Invisalign, like something like, or I should say aligners, not to throw a brand name out there, that will straighten the teeth into where we put the palate. Does that make sense?
Yeah.
So we're using the teeth, when we're using ALF, we're using the teeth to help support the palate and the mandible to where we want it, right? And as soon as we start to see teeth tipping or that, okay, maybe we went too far or maybe we reached the body's limits, right? Then we can talk about, okay, do you like the way he looks? Or would you like to do some kind of orthodontics to straighten it? Or it could even be braces, to straighten that last bit of it.
Thank you.
Yeah, good question. And then one in the corner as well, too.
My question is, does your excuse me, therapy center take medical insurance?
So it depends. It depends. We're actually in the process right now of negotiating with 5 major PPO insurances to be in network. But historically, we've been out of network because it's been such a hassle with the medical insurance. And unfortunately, medical insurance has gotten more challenging over time instead of less challenging. But we're hopeful that with this becoming in network with these 5 through our biller, that we'll be able to cut through the red tape and you guys will be able to get the benefits you so rightly deserve from your medical insurance.
Thank you.
That's great.
That's what it's for. So if I'm snoring at night and my sleep's being disturbed either because of that or because my wife's jostling me, would it be beneficial for me to practice breathing through my nose more? Is that kind of the idea?
That's one of the easiest thing within your control, right? Putting the tongue on right behind your 2 front teeth where that bump is, practicing swallowing in this kind of rhythmic motion, and focusing on breathing through your nose, right? Breathe right strips. If you have nasal obstruction, something like a breathe right strip or a nasal dilator is very helpful to help to force you to breathe through your nose. Sometimes we recommend taping the lips shut, again, to force you to breathe through your nose. Most of my patients that I recommend that, I want it in a V so that you can actually have a little escape window, but you have a beard, so you can't really do that. Those are the things that are within your control.
What about guafenicin?
I'm sorry?
What about guafenicin to help remove any
Guaifenesin?
Yeah, the Mucinex or
Oh, Mucinex. Okay, so if that's an issue, if you're getting excess mucus membrane, mucus secretions through your nose, yeah, that's fine. So, for example, things like nasal steroids, for example, it will shrink up your nasal breathing by almost 100% for 4 hours. And then it has a drastic rebound effect where your nose swells up and you can't breathe at all after it wears off, right? And plus, the preliminary studies showed that it actually changes your brain waves, your EEG signals, from the steroid that's in it, we presume. So I'm not a fan of nasal corticosteroids, right? If someone was an athlete and they were allowed to do, nasal corticosteroids, and we want them to breathe through their nose and they're having a flu or something that stops them from okay, go ahead, do it, okay? But to me, it's not a lifelong solution. I personally make my own nasal spray with essential oils, just over-the-counter essential oils. And just anecdotally, I haven't done a study, anecdotally, 80% of my patients that were essentially addicted to Flonase or some kind of nasal corticosteroid had put it down and switched to my nasal spray and only referred to the Flonase as an emergency. And in my personal opinion, steroids should only be used in an emergency. It depletes our adrenals. There are side effects. You're paying for it later when you have chronic corticosteroid use, whether it's topical cream, nasal, or otherwise. It's fine for short term. A week is fine. But we should only be using it on an emergency basis, in my opinion, if you have no other choice.
And back to what you said about the guaifenesin, I would say that if you're chronically having to use something like Mucinex or a decongestant, there might be something else going on. There might be like some allergy going on, whether it's an environmental allergy or a food allergy, that you can, investigate to see why you're not breathing well at night. And it might even be the case that it's actually happening during the day too, and you don't notice it because you're actually able to drain your sinuses better during the day. But at
Excellent
night,
points.
you're lying down and everything can get clogged up.
Excellent points.
I think that we have to take Dr. Shirazi to lunch. Is there one more question? Okay, one more question. Wait, there's like a fight. Arm wrestle. Okay.
Actually, 3.
Oh, okay.
How long do you recommend breastfeed to fix baby's breathing problem for life?
So, obviously there hasn't been any studies on that. We definitely want it. To me, the absolute minimum in my mind is 1 year. We breastfed my wife. My wife breastfed our son for almost 2 years. If someone did it for 2 to 3, I'm okay with it too. When teeth come into the picture, we're supposed to use those teeth. Okay, so we're supposed to have all our teeth by age 2 or 3. Okay, so all our baby teeth, I should say. We should be chewing food with those teeth when they come out, because whereas the swallowing develops our palate this way, our chewing muscles develop our jaws in this direction, the vertical direction, right? So I often see this in my office. Someone will come and see me and they look, I don't mean this in a derogatory way at all, they look like a Japanese animation character because they have big eyes and a teeny, teeny, teeny mouth, okay? I know that at a very young age they ate predominantly soft food. They did not put their masseter activity to good use. And when they have a little teeny mouth, their jaws are a little bit smaller and they come back up and they have more propensity for a TMJ problem later on. So, in my mind, it's at least a year, 2 years better. Plus the other aspect of it is the first year of an infant's life, they do not have a mature immune system. They get 100% of their immunity from their gut. So whether you're breastfeeding and giving it to them, or you're adding probiotics to their formula, and hopefully you're using like a goat milk-based formula over a soy, that's how they're getting it. They're sincerely not getting immunity for any length of time from anything else other than from their gut.
Thank you so much for coming, and we really appreciate the talk.
Thank you.
Thank you.
Thank you.